My pleasure to introduce Elizabeth, or Fizz Williamson. She's from the London School of Hygiene and Tropical Medicine, where she's an associate professor. Her background is actually in mathematics and medical statistics, so obviously appropriate to her current institution. And she's going to be talking with us today about some of the work that she's been doing on, on coronavirus, and specifically not just some of the findings that they've been having with some of the data sets that she's been able to get access to, but also some of the questions around privacy and open data sharing practices that I think are going to be relevant. So not only timely, but also relevant for all of us to be thinking about in terms of data ethics and the rest. So we'll pass it over to you now, Dr. Williamson, and very much look forward to hearing your talk.
Great, thanks. Okay, I'm just going to share my PowerPoint. Right. Hopefully we're all now looking good. Right, so yes, I'm here on behalf of the OpenSAFELY Collaborative, which is a group that I got involved in right at the beginning of the pandemic. So OpenSAFELY is working on behalf of NHS England. To give you an overview of what I'm going to talk about over the next little while, I thought I'd talk a bit about OpenSAFELY and the systems and the processes, because it takes quite a different approach to this sort of analysis compared to previous models. And then I'll move on and talk a bit about some of our results from our first output. And then, depending on time and enthusiasm, I might talk about another project, or I might just stop and have discussion at that point. I might gauge the audience feedback at that point. Right, so OpenSAFELY, it's a collaboration between the Oxford Data Lab, which is headed by Ben Goldacre, and the London School of Hygiene and Tropical Medicine Electronic Health Records Group, which is headed by Professor Liam Smith. And it's a fairly interdisciplinary group. So there are a lot of epidemiologists, software developers, data scientists, clinicians, people with expertise in ethics, information governance. So a lot of different people brought together in the same collaboration. And what is OpenSAFELY? It's a new platform created specifically to address COVID. In fact, initially it was called Open Corona, but I think generally everyone felt that wasn't a very pleasant name, so we moved to OpenSAFELY. So it's a platform in which data is housed, and currently it contains data pertaining to about 40% of England, and the hopes are that that will soon scale up to fairly close to 100%. And I'm going to talk a bit more about this, but the real key thing is the data never leave the software company. So TPP, which is an electronic health record vendor, so they're a company that provides software to store GP records. So they have patient data and they keep it for the purposes of patient care. And that data never leaves that center. So unlike traditional models where the data is extracted and collated and kept elsewhere for analysis, these data stay exactly where they're collected and stored in the first place. So the key principles underlying the platform are there's internal software that uses tiered, increasingly non-disclosive tables. And the idea is that researchers don't ever need to directly access the underlying disclosive data. I'll go through the exact process, but statistical and data management code is developed not on real data, but on simulated data that's designed to mimic the actual data, preventing the need to actually see the real data. And then your tested programs get pushed to the live environment. And only summary tables and graphs are released from the system, with disclosure of data prevented by a mixture of automated software and manual checking. So before I talk a bit more about that, what data is in OpenSAFELY? Well, it's founded on the primary care data. So the primary care electronic health records of patients who happen to be managed by this particular provider, TPP. And that has been linked to a range of various outcome data. So we have data from the SGSS testing system. So that's COVID tests. with the data, the first test and result. We have A&E data, hospital admission data, ICU admission data, and then CPNS hospital death and ONS death data. And we're increasingly expanding the range of data that's contained in this platform. So the steps of the general process are as follows. The underlying ethos of OpenSAFELY is that everything should be transparent and reproducible. So first, all protocols that are of work that is undertaken in OpenSAFELY has to have an open pre-registered protocol before any analysis can be undertaken. And there's a GitHub for storing protocols, and we're also encouraged to publish them prior to doing the analysis, publish in peer-reviewed journals. They all have to be openly available on GitHub. There's a new code list toolkit. Now, is this an audience that's really familiar with primary care analysis?
Probably not. I would assume, I definitely assume a range of expertise. So dumb it down for us, I'd say.
Thank you. I don't want to be really patronizing, but okay, so when you analyze primary care data, you might, for instance, want a variable that tells you whether a particular patient has asthma or not. And there's no direct measurement of that in primary care. What you actually have to analyze is a list of all the codes, structured codes that are stored against a patient. So for instance, my GP record will have a list of codes for all the prescriptions I've had and the dates, the diagnoses and the referrals that I've had. So if I want to know out of this data set which patients have asthma, I have to create what's called a code list, which is a list of all the codes in whatever coding system. It might be ICD-10 or VNF or SNOMED. So a list of all the codes that I think indicates that that patient has asthma. And creating a code list is actually quite a skilled task. So there's this open system of code lists where if there is a need for a particular variable and there's no existing code list, at least 2 people need to develop it and review a code list and then upload it to this open toolkit. And this is available to anyone. You don't have to be part of OpenSAFELY. So all code lists are then available for reuse. Data management is done by a series of inbuilt scripts, which are internally coded using Python. And that's just a little snippet of how you might define a variable for asthma. And you put in a code list and a date and some other details. And at that point, the system creates a dummy data set intended to reflect the analysis data set that your code leads to. So it has the same structure, the same variable names, and the same variable types as the real data. It's not perfect, it doesn't have exactly the same correlation structure, but we're doing the best to make it as reflective as possible. So at that point, you develop all of your analysis code working with the dummy data. And once it works on the dummy data, you push it to GitHub. It gets pushed to the server and runs against the real data. So through this process, the analyst hasn't seen the real data, which as an analyst who's used to having the data on her own computer, it's really quite disconcerting never to see what you're working with. So once your analysis has run successfully, 2 people need to check that there's no disclosive information. They push back the summary tables and graphs, and then they're available openly on GitHub. Right, so that's the general process. So I thought I'd now talk about the first thing we did with these data. So the team likes to say our first output was in 42 days, but I don't actually know where we came from or to. But I can say it was incredibly quick, and it was a very, very stressful process. So the first thing we did was look at factors associated with COVID-19 related death. And this was eventually published in Nature. So we took these primary care electronic health records and linked it to ONS mortality data. And there are codes in the ONS data indicating definite and suspected COVID-19 death. So the population was 17 million or so adults in England. And we took a cohort study design. So people entered the cohort on the 1st of February of this year. The outcome was COVID-19 related mortality, as measured in the ONS data. And people were followed from cohort start until the end of till the 25th of April, or their death. So that was a period of just under 3 months. And we analysed it just using a Cox regression model and stratified by the Sustainability Transformation Partnership, which is a geographical area. It's a cluster of hospitals, essentially. So we knew that the risk of COVID mortality was going to be heavily influenced by the local rate of infection. So this was the closest we could get to accounting for that. And then we selected covariates prospectively on the basis of clinical interest. Right, so in the database, there was about 23 million people registered with a general practice using this TPP company. We deleted everyone who had less than 1 year of prior follow-up, because previous research has shown that it takes a year or so for someone transferring GP practices to have all of their previous comorbidities recorded fully. So we then deleted children, because the risk factors for children are expected to be quite different. And then we deleted some people for key missing demographic information, leaving us a population of 17 million people and 10,000 or so COVID-19 related deaths. So the absolute risk is really very low. In that period of nearly 3 months, 0.06% in total died from COVID-19 related causes. What's really striking about this is the huge impact of age. So these graphs show the cumulative probability of COVID-19 death over calendar time. So you can see that on the left, at the start of our cohort, there were basically not many deaths, not enough to see for the first month or so. And it's a bit hard to distinguish the different graphs, but the top line is the 80+-year-olds. And the next line down is the 70 to 80-year-olds. And the line below that is the 60 to 70-year-olds. So you can see that each higher age group has a strikingly increased risk. And comparing the right to the left panels, we see that males have a higher risk than females. So it's probably worth stressing that this is our first look at these data, and we were looking at associations in order to generate subsequent hypotheses and as a first step towards risk prediction modelling. So these are not intended to be interpreted as causal estimates. And there was a big Twitter storm of people saying, you can't interpret these as causal quantities. And we said, well, we didn't. So that was interesting. So I know you can't see this very clearly, but this is our findings from that modelling. So these show the hazard ratios and 95% confidence intervals associated with each covariate. So the top one is age, and you can see those little points spreading across the screen show just how striking that age effect is. The next one down is sex, again showing that males have an increased hazard compared to females. The next little bit down shows an obesity trend, with those in obese class 2 and 3 having increased risk. Not much to be seen with smoking. This caused a lot of talk. So in our data, we just crudely grouped ethnicity into white, mixed, South Asian, Black, and other, and all non-white groups had an increased hazard compared to white. And obviously that caused a lot of talk about why that was and whether there were strategies we should be doing to try and mitigate that. There's a very clear trend of deprivation here in the middle, with those most deprived being at higher risk. Uncontrolled and unknown diabetes status, again, higher risk. And as we go down, you can see that essentially every comorbidity included is associated with higher risk. So less so non-hematological cancers, but a strong signal with hematological malignancies, reduced kidney function, not much to be seen with asthma, some increased hazards with chronic respiratory disease, cardiac disease, liver disease, and quite a strong increase for organ transplant. So that's a general picture of what we found. I think my favourite thing that happened on Twitter this year was someone adding the Death Star and fighter planes to our picture. So this is just the numbers that go with that graph. And just to draw your attention to this age hazard ratios on the right here. So compared to 50 to 60-year-olds, those 80 and above are estimated to have 20-fold increase in hazard. So there's this huge age impact. And here, the next one down, males compared to females have a 60% increase in hazard. And at the bottom, we see that strong obesity gradient again. And these are the numbers that go with the ethnicity results. So as I was saying, compared with the white ethnic group, all other groups had a strongly observed increase in hazard after accounting for those other factors in the model, particularly Black. And as we've reanalyzed data with following up for a bit longer, this effect only gets stronger. And then at the bottom, we see that compared to the least deprived, the most deprived have a 80% increase in hazard. So we delved a little more into the ethnicity results, because obviously our initial model had quite a crude grouping. And while once you start breaking down, even with a cohort of 17 million people, you start losing precision, because luckily COVID-19 mortality is still quite a rare event. But interestingly, for instance, if we look in the middle, comparing the Pakistani and the Bangladeshi groups, the Bangladeshi groups have an estimated hazard ratio of 1.8 compared to the Pakistani with just 1.2. So there are some interesting differences when you start delving down within our initial groupings. So following that work, there was a lot of interest in thinking about absolute risks. So when you're trying to inform policy or decide who to prioritise in terms of vaccination or give recommendations regarding return to work, it's really absolute risks that we're interested in. So this is just to give you a flavour of what sort of things we've been doing with that model. So we've estimated absolute risks by age, and this particular graph shows people in the white ethnicity group, non-smoker, non-obese, and estimates their absolute risk by age for individual comorbidities. So the very bottom line in each case is someone with no comorbidities, and then we've estimated it under each individual comorbidity. And this is of interest for a few reasons. Firstly, you see a bit of a pattern emerging. So while COVID was initially thought to be a respiratory problem, in this graph, it's the blue lines that are to do with respiratory function. So we can see that actually absolute risk doesn't really vary very much for people with respiratory disease. The green lines are the ones related to cardiovascular problems. You can see that they're sort of in the middle-ish, so slight increases, but not massive. And it's the organ transplant, immunosuppression, and poor kidney function, which are the ones at the top of the graph associated with the highest absolute risks. So we were asked to look at this in terms of thinking about vaccination at one point, and for them, 65 is an important threshold. So the question that they wanted to know was, at what age does someone with a particular comorbidity have the same risk as a healthy 65-year-old? And what we can see from this graph is that the point at which they hit the age 65 risk, which is this dotted horizontal line, is actually quite a tight range, so perhaps within the 10 years prior to 65. And that's because age is such a dominant feature that in fact individual comorbidities don't massively impact your absolute risk of mortality. However, when we start looking at other outcomes like hospitalization, you get quite a different picture. So here you can see that the differences in absolute risk are really very different. We also see that unlike age, where it was just a smooth trajectory upwards, that the absolute risk of hospital kind of increases once early on and then plateaus a bit, and then we have the big upswing of older age. But the ordering of comorbidities remains fairly similar, with smaller increases associated with respiratory conditions, and then cardiovascular, and then organ, kidney and liver problems and hematological malignancies at the top there. So where are we taking that work? Well, we're currently formalising it into a proper risk prediction framework and looking at what happens when you do proper variable selection and validating it internally and externally. We're also really interested in whether it's useful to try and incorporate measures of the changing burden of infection over time in the local geographical area, and whether that helps predicting absolute risk. So intuitively, obviously, it would help predicting absolute risks, but the problem is, of course, that we don't have very good data. There's certainly not very good timely data about the burden of infection in small spatial areas over time. So we're exploring what can be done with the data that's available in that area. So obviously it's amazing that we were able to assemble this data and get these interesting results, but there are some huge limitations. So the big question that everyone wants to answer is, what's the probability of death given you're infected with COVID? And that's the one thing that we're unable to tease out with these data, because of course in routinely collected health data, there's no measure of who's infected. There is some testing data, but because it was so selective, particularly early on, there's no good measure of who has been infected and who hasn't and when. So while that is the goal, it's not clear that we'll ever have the data to answer that question. Also, there is huge temptation to interpret all these hazard ratios as causal effects. And I didn't draw attention to it, but the hazard ratio for current smoking was slightly below 1. It was something like 0.98. And smoking lobbies jumped on it and said, look, smoking actually cures COVID or prevents you getting it. And we're very keen to promote smoking as a measure, which obviously we were not so keen on. And specifically, that's clearly wrong because we've adjusted for things on the causal pathway in the same model. So it's likely that some of the negative impact of smoking on COVID-related mortality is through effects on respiratory disease, COPD, and other effects. So I do not agree with that. Don't take up smoking. There is some outcome classification, obviously, but we don't think that's going to have a huge impact. Geographically, TPP, the company whose data we're using, are very focused on the northeast of England. The pandemic actually started more in London, so our data doesn't have so much data from London. So geographically, it's not fully representative, but there's no reason to suppose that associations are hugely different in different areas of England. So generally, by far, the biggest risk factor is age. Almost every comorbidity we thought to look at has been associated with increased risk, and that includes cardiovascular disease, diabetes, respiratory disease, including asthma, obesity, history of hematological malignancy, kidney, liver disease, autoimmune conditions. And we saw that people in the non-white groups had substantially higher risk of COVID mortality that only slightly decreased when adjusting for comorbidity, deprivation, and other risk factors. Right, so that's the first block of work we did with the data. The second big block of work, we tried to look at inhaled corticosteroids. Eleanor, is it okay if I push on and do this bit? I haven't been talking that long, have I?
Oh yeah, please keep on going. I think we can save questions until the end. I think we'd all be curious to hear more.
Okay, so I chose this one partly because it was our second big project, but partly because it's at the other end of the spectrum of what we are able to do with these data. So the first project was kind of looking at associations and then developing it through to risk prediction. And the other end of the spectrum, we have trying to estimate causal effects of treatments. And that comes with a different set of challenges and complexities. So early on in the epidemic, people were wondering whether inhaled corticosteroids had a protective effect on COVID outcomes. So that's what spurred this project. So we aim to estimate the effect of inhaled corticosteroid use. So people who were already just in their general care using inhaled corticosteroids on the risk of COVID-19 related mortality. So patient groups who might have been using inhaled corticosteroids, I'm just going to say ICS now, were those with COPD and asthma. So those are the patient groups we focused on. So what was the evidence? Why are we looking at this? Well, on the left here, this simple bar chart, Halpin published a paper early on in 2020 pointing out that people with COPD and chronic respiratory disease were comparatively underrepresented among COVID-19 patients. So these green bars show the percentage of people with COPD and chronic respiratory disease in the general population, and the darker blue bars are among COVID-19 patients. And we can see that there's a much smaller proportion among COVID-19 patients. Similarly, there was a matched case control study of the first few hundred COVID cases identified in the UK. So there the outcome was COVID-19 infection, and they looked at the odds of having asthma ever. And compared to the general population, the odds ratio was 0.73 for asthma, suggesting that, again, people with asthma are underrepresented in those who get COVID infection. On the other hand, there were suggestions that ICS could be harmful by increasing the risk of pneumonia. So we did two studies, one in patients with COPD and one in patients with asthma. So for COPD, we only looked at people who had severe enough disease to warrant therapy, and we split it into ICS-based therapy and non-ICS-based therapy. For asthma, we had a no ICS arm, and then a low dose and a high dose. Now, we anticipated at least the possibility of strong unmeasured confounding, even after we'd done everything we could to account for it. And to try and identify that, we built in a negative control outcome, and we chose to look at non-COVID death. So the theory behind this was the graph at the bottom shows the confounding structure that we were anticipating. So we expect that patients with more severe COPD are likely to have more exposure to inhaled corticosteroids. We also think patients with severe COPD are more likely to have poor outcomes from COVID. So potentially more likely to get infected, potentially more likely to die once infected. And we're looking at the effect of the ICS exposure on COVID death. So that's the confounding structure we think might occur in these data. And obviously we're going to try and account for that through multivariable adjustment. But if we're unable to fully account for that, we may be unable to fully account for that. So our second outcome is non-COVID death. And the reason for picking that is because there's no strong reason to believe that ICS exposure has an impact on non-COVID death. So we expect people with worse COPD to have more non-COVID death, but that any difference to be attributable to the worse health of the patient rather than to the ICS exposure. Right, so in this one we adjusted for a large number of variables selected on the basis of either affecting the probability of either initiating or remaining on treatment, variables that we think might affect the risk of the outcome, so risk of COVID-19 mortality, and then a number of demographic and clinical comorbidities, and then a history of exacerbation to the extent that we were able to measure it. And there's some details about exactly how we defined everything here. So we have age, sex, BMI, index of multiple deprivation, hypertension, heart disease, diabetes, cancer, some immunosuppressive conditions, kidney disease, vaccination status, and some treatment history, including statin use. So on the top here, we have our cohort used for COPD, and the right-hand column shows our ICS group. So these are the exposed people, and we have around 100,000 of them. In the middle column, we have our unexposed people, those who are not having ICS-based therapy, and there's about 40,000 of them. And we've just picked out a few key characteristics, so age, male, whether or not an exacerbation was had in last year, and whether or not the patient has ever had asthma. And comparing the two columns, we can see that broadly speaking, those who are exposed and unexposed to ICS have fairly similar median age and range of age, similar proportion male. We can see that a slightly higher proportion of the exposed group had an exacerbation last year and had asthma in the past. So we're getting a flavour that the unexposed group are slightly less severely ill, as expected. In the bottom, we have the same thing, but for asthma, and now we have the three exposure groups. On the left, we have the unexposed. In the middle, we have the low dose ICS, and in the right, we have the high dose. And in this case, our unexposed group has 100,000 people in. The biggest group is the low dose with 600,000 or so, and the high dose group is, again, about 100,000. And here we see more differences between the groups. Those on high dose ICS are older. They're more likely to have exacerbations. So there is a tendency to have more comorbidities with increasing ICS. So what did we find? Well, the first three hazard ratios and confidence intervals at the top show the unadjusted, comparing the ICS group and the no ICS group for the COPD cohort. The next one down shows the age and sex adjusted estimate, and the third one shows the fully adjusted estimate. And what we can see is that the adjustment does decrease the unadjusted estimate, but not massively. And our final estimate suggests an increase in hazard of about 40% in the ICS group. So remember that the initial hypothesis was that inhaled corticosteroids is protective against COVID-19 mortality, and we're certainly not seeing any evidence of that here. However, if we look down the bottom of the graph to our negative control, while we think that unmeasured confounding, so people with ICS being more severely ill in ways that we're not fully able to account for, would lead to an increased hazard in the fully adjusted model. And that is indeed what we're seeing. So we suspect that that estimate at the very bottom of the screen, the hazard ratio of 1.23, we think that that's probably due to unmeasured confounding, and it indicates that there is some confounding that we have not been able to remove in our model above. Looking at asthma, we see a fairly similar picture. So there's now 2-point estimates for the low dose and the high dose. And if we look kind of in the middle of the screen here, these are our fully adjusted estimates of the hazard ratio for the low dose and the high dose ICS. And those hazard ratios are respectively 1.10 and 1.52. So in the high dose, we are seeing an increased hazard ratio of 1.52 and confidence interval from 1.08 to 2.14. Again, whether that's due to unmeasured confounding or not is a little unclear, although in this case, our negative control outcome largely shows nothing as we anticipated. So broadly speaking, the conclusion was there's no evidence for a protective role of regular inhaled corticosteroid use in COVID-19. We did observe a small harmful effect, but the suspicion is that this is likely to be explained by the presence of unmeasured confounding rather than being a true causal effect. So while we're not recommending people to start ICS to prevent against COVID, we're also not recommending they stop using ICS. So those are the studies I wanted to share with you. broadly speaking, OpenSAFELY is a very new model of sharing data with analysts. So it focuses on enhanced security and timely access to data. Every time we push an analysis to the server, it uses data available up to today. So in fact, if you change a typo and re-push an analysis and run something today that you ran last week, it will have slightly different people in it because anyone who's registered in the last week will now be in your data. So it's really up-to-date data, it's timely. We don't transport large volumes of data, and that reduces the potential of disclosing patient data. Trusted analysts are able to run large-scale computation across almost real-time pseudonymized patient records in a very safe and secure way. And so what we've used this for so far is to look at the factors associated with COVID outcomes, investigate a number of hypothesized treatments, things like ICS and hydroxychloroquine, and try and explore more this ethnic disparities in COVID outcomes. We're currently in the process of trying to establish a pathway for external collaborators to use the data in the way that I've described. And that's just a few of our papers. So I think that was everything I was going to say. Thanks.
All right, thank you very much for that. Let's open this up for questions now. Anyone has any questions, you can do it in the chat or just raise your hand, or we're a small enough group, I think you can probably just call out. Go for it, Yoni.
I have a whole bunch of questions, but I'll take them one at a time and let others ask questions in between across the full range of the work and the talk. But let me talk about the sort of analysis and variable side. As you mentioned, this sort of going from healthy cohort before the pandemic to death combines different processes, of course, and indeed it's possible that some of them may pull in different directions. For example, if older people are in fact less exposed, if they have the sense of staying at home, but then even more at risk when they do get infected, etc. And I'm now thinking more about the first end, the social science end of it, so to speak, the exposure process. Let's talk about that, and the variables, the predictors for that, because your data, because of the nature of it, is very rich on medical predictors, not so rich on sort of demographic background characteristics. Even your deprivation measure is an area level measure where a person lives rather than their own situation. And for example, for those ethnic differences, it might be to do with occupational differences, at least in part, and so on. So the question, long-winded introduction to the question is, are there any opportunities of making that side of the data richer? I guess the answer may be, let's move to Sweden, where the registers are a bit better. But in the UK situation, is there any opportunity of supplementing the data, medical health records data, with something else on this demographic side?
Yeah, so we're exploring a number of opportunities. So things that have been suggested include various sources of occupational data. So we can certainly link to the census, but the timing is kind of rubbish because that's, 10 years old. So I think that's probably worth doing for occupation, because COVID is generally something that affects older people. And I guess once you're sort of 30, 40, you're not going to massively switch occupation. So it's still a little helpful. So we'll do that. And there's been suggestions that there are more administrative pay data that we might be able to link in on an individual basis. So that will be enormously useful. And that would give us quite a fine gradation of occupation. We're also talking to the ONS about what other data we might be able to link together that tackles that more social end, because as you say, our data are pretty crude when it comes to the personal situation. ONS data doesn't have NHS number, which is our primary identifier, so there are issues in linking. And it might be that for some things, the best we can do is link a subset, which of course leads to all sorts of analytical challenges about how then to use that data optimally. but we're certainly working on it.
I can't see everyone properly, so if you've got a question, just call it out. I think.
Okay, I'm going to go ahead with a question then. So just following up on Yoni's point about kind of getting the social side of the data, I'm curious about, I mean, like occupational data would be one set of it, right? Because people might be considered in certain occupations that's shaped by race, ethnicity, and so on, but also by gender, right? So I'm curious how you understand the differences, like why men are basically so much more susceptible than women. Because you could also say that women are also concentrated in occupations, but if we go by that, if we get that data. So I'm just curious to hear what you have to say.
Yeah, I don't actually know. I mean, it's true that one thing that's worth noting is that if you do exactly the same analysis, but put the outcome as non-COVID death, basically everything apart from ethnicity stays the same. So it seems like, to some extent, what we're picking up is just risk factors for death. And men they have a higher hazard of death at the same age compared to women. So it might be purely the same mechanisms that operate just in general. So it's not a very good answer to your question, but no, I don't have any specific insights about that.
Yeah, that was going to be my question too, the extent to which you're just getting general death risk factors. Yeah. Not
for ethnicity, which is the interesting part of that. That's very different.
Could you speak more a little bit about, so you were trying to account for regional differences, but we may also expect there to be regional differences where we're directly interested in studying those regional differences. So, I mean, this is focused on the Northeast especially, right? I mean, now, of course, we know, I'm not sure, that first paper presumably didn't cover that period where you had sort of explosion of cases in the Northeast. But did you is there anything from the regional differences that was sort of notable from the findings that you can highlight?
No, so the first set of work kind of designed it out, so it's stratified on regional differences. So it gave us no sense of comparisons across regions. The work I'm doing right now, instead, it inputs a range of measures of local burden of infection. So one set of models is inputting estimated force of infection, which comes out of dynamic modeling outputs. And another set of models inputs the recent rate of hospitalizations for COVID as a sort of proxy of local infection. And a third set uses GP suspected cases as a proxy for local rate of infection. And those models are able to produce graphs of differences in rates for different regions and incorporate that into measures of absolute risk. I don't have any outputs from that yet, though. to come.
Can I ask a question, jumping to jumping to the very beginning, the platform itself? Because one thing that struck me, this is clearly kind of quick work, amazingly quick work, even for the data analysis. But then you were describing at the start the platform, which sounded like really quite a mature, careful, and in many ways novel way of arranging the data, which is not something that one would expect to see in something that was done at speed in an emergency situation. So what was the background to that? Was that in some sense in development already before all this started, or did it just get done at speed?
I think it really did just get done at speed. So yeah, nothing existed until after the first COVID patient died in England. And I think it was just something that Ben Goldacre has long been a proponent of reproducible, transparent analysis. So I think it's probably the sort of system he's had in his mind for a long time. And it was obviously a good way to go, but no, everything was built up from scratch very quickly. And it sounds a lot more polished the way I presented it than it was at the time. But yeah, it's the first couple of months, I don't think anyone slept. I wouldn't recommend it to anyone.
Thanks. And if I may have a quick follow up on the platform still, you mentioned early on in passing that you would hope it to be 100% at some point in the future, which I take it would mean bringing in not just this one company, but all the providers, which presumably would introduce all sorts of additional complications. So what's the story there?
Yes, that is indeed the hope. I don't know whether that will happen, but one could imagine this happening. So there's, I don't know, maybe 5 providers of EHR across the UK, and 2 or 3 together encompass almost all. So particularly EMIS, if we were to combine data from TPP and EMIS, then that would be most of England. And you could imagine the same system operating. The problem being, of course, it wouldn't then be one data set, it would be 2 similar-ish data sets. And there's a lot of research showing things like the format of the screen presented to doctors in the surgery impacts exactly how they code the same clinical event. So I think the differences between the 2 data sets might be fairly considerable. So as you say, there will be a lot of challenges in figuring out how to combine analyses and what can best be done with that, because it's not as straightforward as just saying, well, we've just tripled our data size. But still, I think a good way to go.
Since we're on the technical side, can we? Oh, sorry, Alia, you were talking, but you were muting yourself. Why don't you go first?
I was just going to jump back to, again, the sort of race difference, and I just want to see the race and ethnic difference. Do you think, like, when you look at the data, do you what you have right now, do you think it is more? Do you think the social data will what you're finding and will explain it, or how do you kind of see that? Where do you think the explanation lies, I guess, is what I'm asking.
My best guess, which is slightly uninformed, is that it's largely occupational. So I'm very keen to get the census data in, because that's the quickest thing we can do to explore that idea. But yeah, I think that will reduce a lot of those discrepancies. I'm not sure it will fully explain it. We do also have information on household composition, and that's another thing that we want to look at, because obviously the more people in the same household, particularly in lockdown, will have had an impact on risk. But yeah, I think it's largely occupational exposure.
So I wanted to ask more a little bit about the mechanics of this, again, building on what Yoni was asking about. So I was intrigued that you were, it sounds like most of the time then you would have been working with dummy data. So I was interested first in how that dummy data is actually constructed, and how are you maintaining correlations between, different variables and things like that. And then I guess moving on from that, what is your ability to do something more like exploratory analyses, given the setup here? I mean, is this really a very sort of hypothetico-deductive, here is my code, I haven't seen anything about the data, this is basically like a pre-registration, and now we will run it and that's it, I'm not going back to the data, this was the test that we had set up and this is it? Or is there some possibility with the sort of live, ability that you have to access the data to still be doing some, I don't want to call it data mining, but let's call it exploratory analysis of
yeah, it's a really good question. So as it stands, it's very hard to do exploratory data analysis. So, you kind of need to know what you want to run and then push it out. So there can be stepped things where you could run a whole bunch of simple tabulations and graphs, and then extract all that information and then think about it. But there's no live interactive, just see about this regression model, and then maybe tabulate that. So it's quite a slow process. If you're not quite sure what you're looking for, I think it could take you months to identify the thing that's been bugging you, whereas it might just take a day if you're in front of the computer with the data. So it's a distinct disadvantage in this way of doing things. And I think those of us who are used to having data at our fingertips, it is harder. It's a lot harder to see where you're going when you don't have a feel for what the data looks like behind the screen. In terms of the dummy data, I think these problems can be slightly mitigated by making the dummy data really good. And that's something that we didn't do at all at first. So the first set of dummy data didn't have the same variable type. So it would be a string in the dummy data and a numerical in the real data, and it crashed and there was errors. And we've gradually built it up so that at least the variable type is correct. But for a long time, the software developers didn't see the need to preserve things like correlation structure. And so we're still talking about how to create data that's sufficiently complex to test data on while not taking forever to generate. So at the moment, you can only have dummy data that has quite trivial correlations. So it's more about, does my code error out because, you know, it's doing a logistic regression on something with 4 categories. So it can pick up those sort of problems, and it can pick up problems about a variable not existing or you've spelt it wrong, but it's not very good as a system for doing things like detecting that there's too much multi-collinearity for a model to fit, or, you know, problems to do with the actual structure of the data. So I've been having some problems with lassos recently. And in the dummy data, my lasso runs on 3 million people in 20 seconds. And on the server, well, it got killed when they rebooted the server after 3 weeks. So there are issues with the dummy data. But it's a system.
But still, it sounds like even the you know, what you're calling a sort of the cruder version that you have now, in and of itself, would be a great resource to loads of researchers, given the ability to, I mean, what that offers in terms of privacy, but also just sort of open science practice of, you know, not looking at data, and so not sort of biasing yourself in one direction or another. Is any of that stuff also up on the GitHub repo, or is that drawing on any work that's out there and available or anything like that?
I actually don't know what's there at the moment. Yeah, I find it hard to tell because I can't tell what's not available to other people when I look. But the plan is that in the near future, people who are not core OpenSAFELY staff will be able to, you know, generate their own dummy data and push results. Obviously, there'll be a process of applying for access and stuff. But the problem is funding has been scarce. So pretty much the whole of OpenSAFELY has been delivered for free. And I think we just hit the point where people can't afford to contribute free time anymore. And there is a need for developer time to make that system work. So yeah, there's a bit of a hurdle in terms of finding money, but hopefully.
Yeah, I guess what I was wondering about there would be just the code to generate a dummy data set in the first place. Whether or not that's available, whether or not it could be for these dummy data is a different point, but just the process of creating a dummy data given a range of different variable inputs and structure and whatnot.
I don't actually know. I think it's done internally. So I've never seen the code myself. I've just seen what comes back when you push your code. Oh, I will ask our software developers.
All right, excellent.
Can I ask and push you a little bit further on the issue that you touched upon? There's these comments that you've been getting about, oh, this is not sufficiently causal to be important, which is silly. Don't want to do this, despite it being a massively important question in an enormously large, valuable data set. So that's silly. But if I can push you a little bit about what you said, it is associations. What exactly does that mean here? What I have in mind is that when you have a model where you control for a whole hell of a lot of confounders or control variable, let's call them, the easiest way to look at that is to think of it as being at least pseudo-causal in aim. Interpreting it purely as an association is a bit more difficult because that actually involves imagining sort of similar individuals who are similar in all of those many other things, and then imagine, okay, how do they differ in remain? So if you look at associations, you are in a way more interested often in looking at collapsing over other things, and maybe even those your absolute risk plots perhaps were in effect averaged over other predictors. I'm not sure, but my basic question here is what do you mean by associations, and how ultimately do you want to talk about what comes out of these models?
Yeah, well, so what I view these results as being a precursor to two things. On the one hand, risk prediction models, and on the other hand, causal studies. And I think that with a sort of thoughtful, careful interpretation, these results can help you think about both of those things. So the risk prediction is more obvious. Like, essentially, what we have could be a risk prediction model. It just hasn't yet been externally validated. So I think it does give you quite a clear picture of, if I wanted to predict risk, what sort of predictive power would I have, and what would be associated with higher and lower risk. So that's kind of an intuitive way of using the results. The other side, where you want to think about individual characteristics and think about whether they have a causal effect on the outcome, I think these results are quite helpful, but you just have to be a bit cautious. So if you were to, for instance, want to know about the effect of smoking on COVID-19 mortality, you couldn't look at these results and say, here's the answer, because we've adjusted for so many things that you shouldn't put in a causal analysis of smoking. So I don't think you could draw any conclusions about that. But on the other hand, if you wanted to know about some of the more upstream factors, I think if you were to design a causal study specifically for them, then this is more or less what you'd end up with. So I don't think it's unreasonable to attach a more causal interpretation to many of the chronologically later events that are included in our model. So I think it's more just that you have to be a bit cautious about what you read into things. And when it comes to the ethnicity, we were soundly criticised for implying that our ethnicity results had any importance at all, because we said, this is something that needs to be looked at more. And we were very criticised for that, because these are just associations. But I think that if you went back and did a fully causal analysis of ethnicity and did a proper mediation looking at how much of the effect was mediated through deprivation and comorbidity, you would come up with a conclusion that we've already come up with, that not a lot of it is, that largely it remains. So I think that you can infer a lot about the causal effects, as long as you're a bit cautious.
And do you see any other prospect for doing other sorts of causal identification tasks with these data, using any, a matching approach or any other attempt at causal
so
inference?
I think we're doing some matching studies at the moment, and we've done some propensity score analysis. In fact, I think we also did the ICS using a propensity score approach. And I'm also quite keen to look at some instrumental variables related methods. So there's a method called the residual inclusion method, which sort of combines regression approaches with trying to use something like the GP practice as an instrumental variable. So I think that might be worth exploring in these data, because it's definitely true that there's some unmeasured confounding in some of our questions.
Just one small more question from me, and I think your Nature paper went up to whatever it was, May or April or something like that. But clearly, the platform is set up in a way which seems like, especially since you know which code to run or which model, no exploration left, that you could pretty much press the button every day and get today's version of these same models. Is that something you do?
Well, so initially, that was what the data science part of the team thought was the idea. So they were intending to have a sort of live Nature paper that changed the hazard ratios every day according to the data. And the epi part of the team were like, what? No. So I think we've come to a sort of compromise whereby some things are going to be updated, like maps and trackers, and that will just be daily updated. But some analyses, like particularly the causal analyses, are just going to have one version and then we're stopping.
Could you say how the propensity score would help you? How the matching? What would that help if you're missing variables?
So I suspect not very much, which is why I'm placing more faith in this residual inclusion idea. The propensity score relies largely on the same assumptions as the multivariable regression modeling and the matching. So if you can match on exactly the same bunch of variables that are in your multivariable regression model, that are in your propensity score model, they should all be doing the same thing.
Yeah, okay.
So I was ignorant there. Why were the epidemiologists not keen on having the results be updated iteratively?
I guess if you do a causal analysis, then I think you generally do a lot of quite careful thought about the results, and say for propensity score analysis, you would look very closely at whether that particular model has achieved balance between the exposed and unexposed. And then you would compare the results for your negative controls to your real outcomes. And there's a lot of thought in how they all tie together and what the interpretation should be. And so I guess people are just a little bit nervous that if it was automatically updated, that those checks wouldn't be made and the interpretation wouldn't be well thought of, because no one has time to update the discussion session every day. So I guess that was the concern.
Go for it, Xiaoyu. Yeah.
Oh, thank you for your talk. I actually also have a question more about the platform. Although you say, the platform, there's a hurdle for that now. Like, is there any attempt to expand the project to other countries to have like a more comparative study? Because when I was looking at the results, I was wondering like if what we see based on the UK data, is that how much of that is, specific to the UK, and how much of that like is more like the general, or what can we learn from, this data, so massive data from UK?
I think that the sort of general patterns that we've seen in our data have been reflected in studies internationally. So I think the associations and things, a lot of them can be generalized to other countries. Although I think some of them, like the ethnicity associations, are probably quite context specific. I think the US found very different patterns of association across different ethnicities. But in terms of the platform itself, I'm not aware of any other countries having exactly this system. Certainly it's not the case that we have international collaborators doing the same thing.
So even, sorry to jump in, so even the countries which normally have a kind of better opportunity of doing this, the register countries, Nordic ones and so on, they haven't done this?
Well, I'm not in a position to say that. I'm not aware of them doing it in this way, but then I haven't really explored what other countries have been doing. I certainly don't work with anyone who uses this sort of system. So yeah, I don't know. It's the first that I know of this model, but that's not to say it definitely is the first.
And I guess one further question would be, how are your findings being used beyond, getting published in Nature, right? What conversations is the team having with the NHS, with with government, with other organizations to draw on the findings?
Well, yeah. So Chris Whitty and Patrick Balance have been in communication with us a lot about particularly the treatment effect side of things, and staying up to date on what we found about the ICS and the hydroxychloroquine and those sorts of things. The stuff I was presenting earlier about the risk, that's been feeding into a lot of advisory groups, like the issues to do with who gets vaccinated, advice on return to work, advice on who should be shielded. So there's a lot of committees who've asked for reports from us about absolute risks and comorbidities and the ethnicity disparities that we found. So yeah, we're doing a lot of reports.
I can add one thing here from the LSC perspective. I have been very peripherally and briefly involved or consulted about some things, decision making here in the school, and already at the stage when it was still a preprint before the paper came out, this your paper was one of the first that reached my desk from some higher ups in the school, in the context of risk assessments for staff, things, in particular the age effect and the very, I don't know, obvious nature of it was involved in those discussions. And then when I'm not fully involved, so I don't know what was done with it, but it was definitely there as one of the very few key pieces of evidence. So, and I assume that sort of use of it has happened in very many organizations across the country and elsewhere.
Yeah, it's the first time I think that my work has ever been relevant to anyone. It's quite interesting. It's quite nice.
Given the discussion that's been happening now so much about decisions for schools and whether schools should be open and online versus online and the rest, could you be doing equivalent analyses with the under 18, that set that you excluded from your analyses here?
No, it's very much on our to-do list. I think part of the problem is that it was just so hectic the first few months, and now everyone needs a holiday. So yes, that's certainly high up on the priority list. But I don't know if we've done much about it yet.
And the funding side, anything coming? That should not be a very difficult application to write for research funding.
So I don't know why we don't. We have more. We've got a few little bits of funding, but nothing substantial. Yeah, it's weird.
It is.
Could I ask why your estimates of the mortality rates, they were pretty low relative to what one has read in the beginning? What are the reasons for this? What do you think?
Our estimates of the mortality rate are low compared to...
Yeah, to what I heard in the very beginning, like you had this 0.6% or something like this on one of the first slides. I'm not sure what numbers you're comparing it to. I think in the beginning, roughly like most of the articles were around 1% or something like this. And I just wanted to know, like, did this evolve over time? It's not my field at all, so I don't know. I have no idea.
I don't honestly know. I haven't actually compared the absolute rates between different sources.
Okay.
It may just be a time period thing because our data, I guess our data includes the peak where it went right up and then right down, there's a bit of a plateau. So it may be that the estimates that just had the peak in it were quite a lot higher. Possibly.
Okay. I might be able to find one of these papers. Give me 1 second.
You don't think maybe it was like, mortality rate given hospitalization or something like that? I mean, maybe it's a very different population base that it's being compared to, potentially. Right?
Because presumably, Fizz, your numbers were kind of accumulated for this analysis from those models. So essentially starting from a healthy population and then applying the hazards day by day, so to speak, until for that period time window.
Indeed.
Which is very, very different from the percentage of those infected who die.
Very different, yeah.
I think, 1 second. So I had this here, I think. This was a Lancet paper from March. And this had, I think, a mortality rate of like, it was pretty much like yours, like in the 0.6 or something. Okay, cool.
Okay.
Okay, good. So I understand. Cool. And then the condition on hospitalization, that is a very different thing then, of course. That's right. Yeah. Okay.
Yeah. And we didn't look at any hospitalization stuff at all because there are really good hospital data out there, and that's not what we can offer that other people can't.
But on that, sorry, I've got a million questions today. That is a piece where kind of there's sort of some additional information to what you were looking at. Think about the age in particular. If it's the case that the first part of the is chain of death, which is exposure, is actually less for older people, then it would be correspondingly even larger from infection to death or hospitalization to death, where you, as you said, it's easier to have data and other people have done it. So what do you know in those other studies which have looked at age effects for that step, hospitalization to death, mortality there, how high are those age effects, and are they indeed higher than what you have?
Actually, no. I know they're very striking. But because we've all used different reference categories, I can't actually give you the exact numbers, but it's something I should go and look at. It's a very good point. Yeah, thanks. Good suggestion.
Are there any last questions? I think let's take them now. Otherwise, we've drilled Fiz enough here with all sorts of different questions. We can release her back to doing good work.
Is there one question, because you're the expert on these kind of things? Is there a lot of research on what drives these long-term effects of COVID? If I think about people that I know that had it, I know very few that, or actually no one that went to hospital, but I know a couple of people with these really long-term kind of fatigue, brain fog symptoms. And is there research on what drives this? Is there like do people use genome data and try to predict whether people have some stuff on their genome that drives this, or what is this?
Yeah, so there's quite a few different projects looking at this, and in fact, one of the few bits of money we have is to look at this. So we're able to look at people who go to their GP with these sort of symptoms and track them over time and try and explore differences in who does and doesn't have that outcome. So we're certainly doing some work along those lines. In terms of the genomic work, we're not leading any work with genomics, but there certainly are other projects out there, and I'd be very surprised if no one was linking to genomic data.
Cool.
All right, well, let's all give Fiz one more round of thanks, and yeah, thank you very much for filling us in on all the very important and yes, definitely relevant to the world work that you're doing. Thank you very much. Yeah. Okay. Thanks everybody, and have a good rest of the week.